This is Shadar Cases, Case 1, Analysis A. This is Ellen Madono, and I'm asking you to please keep your own notes, and there will be a PowerPoint copy loaded on to the area next to the video under Case 1. Now, I'm doing this for my own purposes, to learn the background to Dr. Shadar's thinking as deeply as I can. But I'm trying to speak to people with different backgrounds. So if it sounds like I'm saying something that's too simple or too obvious or something that's too deep and beyond you, don't worry. I'm trying to address different people. I have only a basic background in pathology that's required for homeopathy. And I'm only going to be describing pathophysiological phenomena to some extent because this information helps me. It's not because I'm an expert. I hope we can get help in the discussion from Nader. He's an expert. This is the third time for me to do the course. If you are a newcomer to Shadar Cases, absorb what is useful for you now, and you can do the course again later. A deep pathological knowledge is not required to do the course, so really don't worry. Dr. Shadar says, the case is a never been well since case, NBWS, never been well since case, following an infection, IM, infectious mononucleosis. In such cases, the presenting symptoms and the original symptom make up the picture that is the target of homeopathic action. The primary infection is not resolved in this patient, and he is suffering from an internal struggle and still showing components of the primary infectious state of IM. The infection by EBV. So the primary infection is infectious mononucleosis. Okay, this is what he had, the infection that he had originally as a child. And he's suffering from an internal struggle. And so components, parts of the original disease, of the original primary infection, remain. And this is an infection by EBV, the Epstein-Barr virus. So he's saying, like a puzzle, pieces of IM are forgotten, and pieces are also missing. They're not there. Okay, so we have an incomplete picture of the disease, that the primary disease, the first infection of infectious mononucleosis. Now I want you to think about the underlying dynamic state. The remedy should be prescribed according to the changes following the infection. If we knew the details of his primary infectious state, the peculiarities of his IM symptoms, we would be able to consider those symptoms too. Although the primary state seems to be not present now, it is actually present in the underlying dynamic state of the patient, but it is distorted by the secondary defense mechanism of the organism. So the organism here is the patient, right? And dynamic means that it can be changed. That means it can be cured. There's an underlying dynamic state, changeable state. Underlying means that it's not totally visible in the symptoms that are presented in this case. Now, this idea of secondary defense mechanisms is probably very familiar to you in psychology. We keep others at a distance because of fear. This is a kind of psychological defense mechanism. We ignore problems out of fear. And you probably have patients like this who are aggressive out of fear. Now, there are also secondary defenses that are physical adaptations. All of these previous examples are psychological adaptations, right? So now we're going to talk about physical ones. Now, this is kind of a joke, but has this gorilla adapted to lower back pain by getting long arms instead of a cane and hunching over? This shows the progression of pain in the lower back. And there are multiple causes for this final state of her elderly state. I'm suggesting she could have a prolapsed uterus. She could have injuries. She could have work stress. A prolapsed uterus means that the uterus is sliding down. There's pressure here from the organs down here, and it's sliding down into the vaginal tract. This is a very terrible situation, obviously. But, you know, this could be one cause for looking like a gorilla. Now, there are other diseases that we're familiar with. There are multiple layers in the blood vessels. And say there's a tear in the inner layer. This is the common cause for the collection of plaque or scar tissue to patch up that tear. That's the secondary defense. And as a result, a pathology develops. That is, a clot leading to a stroke develops because this original scar tissue attracts other garbage that begins to attach to the wall of the blood vessel. So we're going to return to the case. Just keep those thoughts in mind. And there were forgotten symptoms of IM. The symptoms of IM could be in the brain. They could be in the tissues of the mouth. They could be in the inflammatory materials could come down here further to the neck. They go into the lungs, to the spleen that would be over here, to the liver that's over here. And to all the lymph nodes, okay? But we don't know what these symptoms were for this boy. And furthermore, as homeopaths, we're looking for the symptoms that are peculiar to him, that individualize him. So he doesn't remember, and he was a child, he was a teenager. So we're never going to find these symptoms out, no matter, probably his mother won't remember. So what do we know now? Now we know that he has an internal struggle in these glands here at his neck. Okay, and this is a very typical symptom of IM, infectious mononucleosis. And he has other symptoms. I'm not going to go over them, but these are all places where there appears to be a struggle or a chronic infection going on. So, in summary, the secondary defenses are adaptations to pathological conditions. Now, do we repertorize these symptoms? Why or why not? Okay. I mean, we don't have the initial primary symptoms. We don't have them. So, we can't repertorize the initial symptoms. And since we don't, We have to repertorize these symptoms, the symptoms we have. This is kind of basic to homeopathy. You repertorize what you can get, but you better know what it is you're getting. So I'm asking, is there an absolute answer to this question? And think about it. Is there? Consider the situation of this case. Is this case always true? Here is Dr. Shadar's repertorization, and I'd like to look at how he's done this. Okay, if you draw a line here, you see that you have rubrics here. These are rubrics with many remedies in them. And here there are fewer remedies. Okay. So it's very important to keep track of this vocabulary if you're a beginner. Symptoms, Dr. Shadar keeps talking about symptoms because he's not selecting rubrics. He's selecting symptoms first. But what you pull up on a chart like this are rubrics. These are found in the repertory. Okay, so let's differentiate them. Now, is there anything tricky about his repertorization? Okay, we see some symptoms that are based on observations rather than the patient's report of his symptoms. So the patient is loquacious. He didn't need the patient to say, I am loquacious. He only needed to say, watch him, and he was talkative. And so loquacious is obviously repertory vocabulary. It's not a common word in English anymore. But that's about as tricky as his repertorization goes. There's nothing very tricky about it. It comes directly out of the case. Okay, so I'm going to ask some more questions about these, but later. What is the rationale for the symptom choice? We've gone over in the discussion what the characteristic symptoms of IM are. Out of all those symptoms he could have chosen, why did he choose the individualizing or the peculiar symptoms? Now, how do you know which symptoms are peculiar? Let's look again at the repertorization. These that have so many remedies under them are not peculiar. They're common symptoms. These ones that are under 150, these are still pretty common. But these here are very individualizing. They're low number of remedies in them. Okay, so those are more peculiar, but they're not extremely peculiar, I don't think. And then also, I wonder why he chose two rubrics to talk about memory and loss of concentration. Why did he use two rubrics? Or the throat pain and the pain on talking, the throat cervical glands and the pain on talking. These seem like very similar rubrics. I mean, they're pointing to the same phenomena, and I don't really have an answer. I have to ask Nader about this. I'm not quite sure. Now, I've already pointed out, you want to look at the number of remedies in each choice and look at the whole list, and are there some clearly top remedies? And do those rubrics have anything in common? Okay, so here are the numbers. And if you look down here, this is the order of the strength of each remedy that was selected. Okay, so do we have a clear differentiation between here and here? I'm not sure. Is it easy to choose between these remedies? In general, this is called a kind of a square or rectangular repertorization, because there really isn't that much statistical difference between the remedies. Okay. Now, Dr. Shadar's conclusion is a good prescription should cover both the common and the peculiar symptoms. So he's saying we need these symptoms and the more peculiar ones. We need them both. You can't cover one or the other. And the peculiar symptoms should not be sacrificed for the common ones. Okay. I don't quite understand the implication of this, because usually we concentrate on the peculiar symptoms. That's what we're usually told. So visually, where are the common symptoms? Okay. And how are they different from the less common symptoms? Will Taylor, I think he said 160 remedies should be contained in a rubric that's going to make a statistical difference. It wasn't 260, was it? Now I'm suddenly worrying. Okay, anyway, those common symptoms, these common symptoms here, are way above 260 or 160. Okay. Okay, so my question is, why does Dr. Shadar use common symptoms? Does it seem obvious to you? Why did he decide to count the symptoms that have no statistical value? Why is he even looking at them? Now, given Dr. Shadar's analytical techniques, why does he make these suggestions? Are there other repertorizing strategies? Are there other confirmatory strategies? Okay. We'll get to this word in a minute, but just consider. Now, I've used my program to try to just repertorize the symptoms that are individualizing, that are of statistical value. And if you compare this list to Dr. Shadar's list, a lot of the top ones here are also in this other one, in this list here. Okay, here's pulsatilla, here's kaliiodidum, Rustox is here, iodine is here. And does it really matter to have those common symptoms? Why is he insisting on this? Okay, I'm not sure. We can discuss this. Could any classical strategy produce similar results? Okay, there are other strategies out there, for instance, one that just emphasizes strange, rare, and peculiar symptoms, or some kind of symptom hierarchy. Usually aggravations and sensations are on top of these symptom hierarchies. And then there are other confirmatory strategies, for instance, facial analysis, or this is supposed to be or polarity analysis. I don't know too much about this, but both of these they seem to be confirmatory strategies. Okay, they're ways of. This one is a way of analyzing remedies, the value of remedies and the symptoms that are used. And this is a very, very different kind of miasmatic analysis. I think what Dr. Shadar is saying is that the problem is not clearly defined if the large rubrics are not used. I don't think you need to have large rubrics necessarily, but you definitely need to make sure that you're encompassing the pathology, the actual pathology. And we know that this is a never been well since disease of a very clear pathology, and we have to be sure that we're covering that pathology. So these common symptoms that Dr. Shadar gives us, these symptoms here are the common symptoms of I am. Okay, these here are getting more specific. These belong more to the individual. Okay, lassitude in the morning, in bed, aggravated. This is, lassitude would be I am, but in the morning, in bed, aggravated, not necessarily I am. Okay, loquacity is not required for I am, or you don't have to have a generally warm body that doesn't tolerate warmth. Okay, so I guess that ends the analysis of case 1. Thank you very much, and please join in the discussion, and then we'll go on to the next analysis later. Okay.